Today we're going to talk about anesthetic emergencies. Certainly the goal of anesthesia is to maintain the patient in a stable physiological state throughout the course of anesthesia and surgery. But anesthesia and the human body are very complex. Emergency situations in the operating room may be due to existing disease, trauma, the surgical procedure, anesthesia, or unknown factors. Two of the most pertinent emergency situations relevant to us, the surgical techs, are cardiac arrest and malignant hyperthernia. But first, we are going to look at respiratory emergencies. Your book talks about three major emergencies: bronchospasms, anaphylaxis, and laryngospasms. Intraoperative respiratory obstructions can cause many things like swelling from trauma, inflammation, and allergic reactions. In times when we cannot establish an airway, we may have to perform an emergency tracheotomy. If the anesthesia provider sees any signs of even a mild allergic reaction, we immediately discontinue the triggering medications and ventilate with 100% oxygen and increase IV fluids to flush the body's system. The protein that is released when it recognizes an allergen or inflammation is called histamine, which is a vasodilator, swelling of the blood vessels, and it causes hypertension, which is low blood pressure. Vasodilation causes more heat carried to the blood of the skin. Bronchospasms occur when the airway or bronchial tubes go into spasm and contract. It is extremely serious and it could cause brain injury or death of our patients. Most of the cases we will see are caused by chemical or mechanical irritation when the anesthesiologist places the ET tube during intubation, and your airway gets inflamed just like any other part of the body when a foreign object is placed. Some patients with an increased chance of bronchospasms are patients with COPD, mucosal edema, which is the obstruction of the sinuses, increased mucus production, and inflammation of the airway. Signs of bronchospasms are wheezing, prolonged exhalation, which normally we breathe out less than 5 seconds. In this situation, theirs is longer than 5 seconds. A decreased oxygen saturation, which is the arterial blood oxygen level, are below normal, and this can compromise our heart and brain functions, and an increased airway pressure and hypotension. To treat, we first have to look at the ET tube to see if there is any blockages, or if the tube became loose. If not, then we give 100% oxygen and manually ventilate. Medications we would give would be albuterol, which is given through the ET tube, a nebulizer to relax the muscles of the airway and to increase air to the lungs, people with asthma or COPD. Adrenaline or epinephrine can also be given as an aerosolized version through the ET tube to relax the airway. And lastly, atropine also works the same way. If we cannot get that spasm to stop, anesthesia would administer anti-inflammatory agents through the IV. Anaphylaxis. Anaphylaxis is a severe systemic, meaning inflammation has spread from one area to the other, allergic reaction in patients caused by a triggering agent. It is the most severe type of hypersensitivity to any medications, latex, anesthetics, or blood administration. An example is someone that is stung by a bee and they went into anaphylactic shock, which means that there is a complete cardiovascular collapse. The most common neuromuscular blocking agent that causes this type of allergic reaction is acetylcholine. A neuromuscular blocking agent is the most common. Signs occur really fast within 2 to 30 minutes, and they can last up to 36 hours. Patients can present with hives and again show signs of cardiac arrest through their vitals, hypotension, and respiratory distress. To treat anaphylaxis, the first thing we would do is to give a bolus of epinephrine through their IV. A bolus is a rapid push of a one-time drug dose into your IV. Since epinephrine is short-acting, anesthesia may have to administer this more than once should we need to resuscitate, again giving more IV fluids. Transfusion reactions. They are rare, but they do happen. And when a patient has a reaction from a blood transfusion, we would have to definitely treat this, and the anesthesiologist would take the lead. There are 3 types of reactions that may occur. The first, being febrile, non-hemolytic, non-causing, occurs when antibodies bind to donor white blood cells or platelets. This is hardly ever seen in the operating room. The second type, allergic, is pretty mild when this happens, and medications are taken by the blood donor or additives in the blood during preparation. We can treat this like any old mild allergy, and that is with Benadryl. The third type is hemolytic. Happens when we mix incompatible blood or blood products. When this happens, the patient oftentimes gets hypotensive, has hemoglobin in their urine, which means that our red blood cells have broken down and they are moving freely in their bloodstream, and their levels are too high, causing their blood to be thicker, which leads to clots, heart attacks, and strokes. Or from anuria, which means that the kidneys aren't producing urine. Or DIC, disseminated intravascular coagulopathy, abnormal clotting throughout our body's blood vessels. To treat, we would have to discontinue the blood products immediately, control the hypotension, and if needed, administer diuretics to restore and maintain the patient's kidney functions. Laryngospasms. A laryngospasm is a muscle spasm of the vocal cords, sometimes called a laryngospasm. While a mild laryngospasm, where you can still exhale air, can be frightening, it is usually not dangerous and typically lasts only a few minutes. This happens when the involuntary constriction of the vocal cords may result in complete or partial closure during intubation or extubation. This can happen in pediatric patients as well, where you will hear a high-pitched sound called a stridor. Infants are more at risk between birth and 3 months, and those with asthma or upper respiratory infections. To treat, we have to give positive airway pressure using the chin lift maneuver, and if it progresses, a muscle relaxant administered, possible reintubation. So to recap, the 3 respiratory emergencies are bronchospasms, anaphylaxis, and laryngospasms. Moving on to cardiac arrest, another pertinent emergency that happens in the operating room. Cardiac arrest is sudden. It is an unexpected loss of cardiac function, breathing, and consciousness. It can occur at any time, before, during, and after an anesthetic. It can happen for a number of reasons. Some of the medications can cause irritability or arrhythmias, and some patients who have cardiac disease. In the operating room, we call it a code blue. This is called in every operating room and alerts all staff. Anesthesia runs the code. If we do not hear a pulse from the ECG leads, we begin manual chest compressions. Any team member in the room can do this, and we switch out. Once a code is called, a team member goes and gets the crash cart. Every operating room has a crash cart, which is normally found in the core. You need to know where the crash cart is at your clinical site. The crash cart has defibrillators, child and adult size, a backboard that we place under the patient to allow for deeper chest compressions, emergency medications, and a tracheotomy tray. All crash carts must be plugged in at all times. Do not forget to unplug the cart if you are the one retrieving it. Turn on the defibrillator and apply the defibrillator pads. Anesthesia will direct you. The surgical technologist's role in a cardiac arrest. It really does depend on the time of day and if the incision has been made, but your first thing is to always maintain the sterile field. If you do not need to stay scrubbed if the incision hasn't been made, you can certainly go retrieve the crash cart. You can also be the record keeper and also perform compressions. There is a full list of important factors on page 223 of your text. No matter what role you have, it is always vital to keep your senses open and listen to the medications being called out that are being used during a code and what their purpose is. Epinephrine, the hormone to get the heartbeat back, acts like a vasopressor. It causes vasoconstriction and raises blood pressure. We administer the bolus through the patient's IV, a short-acting jolt to jumpstart the heart. If no changes, we redose during resuscitation. Another first-line drug we can use is vasopressin. Instead of giving a first or second dose of epi, we only give this once due to its longer duration of action, and it causes intense peripheral vasoconstriction to support the heart's blood flow during cardiac arrest. These medications are ultimately used to raise the patient's blood pressure. Oftentimes, if you are actively involved in a case and the incision is made and you notice the blood pressure dropping, the anesthesiologist will administer pressors for short, and the surgeons hate when their patients are on pressors because of the vasoconstriction of their vessels. So oftentimes you will hear the surgeon say, "Is the patient still on pressors? Why are they still on pressors?" Miscellaneous cardiovascular drugs. There are many types of cardiovascular drugs available. The most common are listed in your book. Adrenergic agonists. We use these agents because they mimic the effects of epinephrine and norepinephrine. Norepinephrine, when used with epinephrine, increases the heart rate and blood pressure. An example would be dopamine. It increases blood pressure, which is used to treat bradycardia. A normal blood pressure is 60-100 beats per minute. Bradycardic is less than 60, meaning your heart is not pumping enough oxygen-rich blood to the body. Another example is dobutamine, a chronic cardiac failure. Albuterol is also used to treat a bronchospasm. Adrenergic antagonist is an agent to block the effects of epinephrine and norepinephrine. These are more like beta blockers, and they are used to slow the heart rate, tachyarrhythmias or abnormal heart rhythms, and hypertension. Cholinergic agonists and antagonists mimic effects of acetylcholine, which is a neurotransmitter in the parasympathetic nervous system, and it slows the heart rate, conserves energy, and relaxes the GI tract. Atropine is used to treat bradycardia and raise the heart rate when needed. Antiarrhythmic agents are used to prevent or treat irregularities in the force or rhythm of the heart. Vasodilators. They are agents that relax our smooth muscle cells within our blood vessels walls to reduce blood pressure and enable less restricted blood flow to our vital tissues. An example is nitroglycerine, and that is used to treat an MI and a CHF, myocardial infarctions, and congenital heart failure. Inotropes and vasopressors. Inotropes and vasopressors are used interchangeably and are given to increase the force of our cardiac muscle contraction and increase blood pressure. Box 16-1 shows a complete breakdown of examples for you on page 225 of your text. Malignant hyperthernia, which is such a rare but life-threatening reaction and is triggered in patients when administered with certain anesthetic gases. MH is an inherited muscle condition that causes hypermetabolic state. Hypermetabolism of the patient's skeletal muscles leads to hydrolysis of ATP. When the inorganic phosphate is released during the hydrolysis of ATP, it makes other compounds more reactive in our body, increasing the energy currency in our body, which causes extreme muscle contractions from calcium buildup. Remember, ATP is energy currency of the body. Aside from increased energy, it leads to an increase of oxygen consumption and heat production. The first unexplained sign of MH is tachycardia, heart rate over 100 beats per minute. Fast heart rate can lead to heart attacks and strokes. Patients will also present with unexplained rise in end-tidal carbon dioxide, which is the maximum concentration of exhaled breathing. It is estimated that 1 in 50,000 adults and 1 in 15,000 children are susceptible to MH. If left untreated, patients develop numerous metabolic abnormalities, one being rhabdomyolysis, a muscle cell breakdown, or respiratory acidosis, when your lungs cannot remove enough of the CO2 produced and it causes our body and blood to be too acidic. or